Welcome back to RhAPPcast, the official podcast of rheumatology advanced practice providers. I'm your host, Amanda Mixon, and you're listening to the second installment of our GCA Fireside Chat series, a program that is designed to provide clarity, clinical insight, and real-world experience to the evolving care of giant cell arteritis. Today's episode takes us beyond diagnosis and into the complex world of treatment. From high-dose steroids to steroid-sparing agents like IL-6 inhibitors and methotrexate, the treatment landscape for GCA has expanded, but also so have the challenges. Joining me today are two expert guests who bring deep clinical and research experience to the table. Naomi Amudala, a nurse practitioner, and also Dr. Michael Putman. Naomi, you were able to provide an introduction on our first episode of the series. Dr. Putman, since it's your first time on RhAPPcast, would you mind providing us with an introduction?
Yeah, of course. I'm Mike Putman. I'm an associate professor of medicine at the Medical College of Wisconsin in Milwaukee, Wisconsin. I am heavily involved in education there. I'm the program director for the Rheumatology Fellowship and an APD for internal medicine. But my main clinical focus is vasculitis. I run the vasculitis program at MCW. I participate in clinical trials in vasculitis, and I do a lot of observational data, some big data epidemiology projects, often in vasculitis, but I'm kind of a generalist at heart as well. So I do a little bit of everything. I do a podcast myself. I host the evidence-based rheumatology podcast whenever I can find the time to get on some episodes. And I participate in ACR a lot. I'm the current knowledgeable host. So if you want to see me make a fool of myself in front of a lot of people, myself, Didim Sajan, and Joanna Marco are the three co-hosts for this year. So please come watch. It's a lot of fun at ACR every year.
That's awesome. Well, gosh, I'm so excited to have you here. And I think this is going to be a really exciting episode. Our listeners love all of the stuff that we provide for them. So let's just dive right into this. So whether you're revisiting the fundamentals or you're looking for advanced clinical pearls, hopefully this episode will give you a thoughtful, evidence-informed view of where we stand and where we're headed in the treatment of giant cell arteritis. And, just as a starting place, I think about giant cell arteritis when I first started, and I've been in rheumatology for 18 years. And really, it was steroids. I mean, that was it, for quite a long time. So obviously, we've made so much headway in this field, and again, more to come. So on that same note, Naomi, I'm just going to go ahead and start with you. So let's talk a little bit about the available options. So as a global overview, what are the current available options for treatment of giant cell arteritis, and how are they typically used in clinical practice?
Well, thanks so much for having me. I think, as you mentioned, prednisone is always a mainstay when it comes to treatment in giant cell arteritis. But as anybody knows, prednisone is not ideal, and it's not safe to be on long term. And so fortunately, we do have other options. For the longest time, it was just methotrexate. I mean, that's our old standby for pretty much anything. And then with the GIACTA trial, of course, we now have tocilizumab on the market. And then most recently, upadacitinib was recently approved as well. For me personally, I think it's always kind of a discussion that I have with the patient. I go through all the options. We talk about methotrexate, we talk about tocilizumab, and we kind of weigh the pros and cons and decide what drug would be best for the patient. I don't know, Dr. Putnam, your experiences, or if you have a kind of a go-to drug that you always prefer.
I think that's a great rundown. Those are all the major players. And I think, the standard joke is you put two rheumatologists in a room and you'll get 7 opinions. And I think that holds true for GCA management. Prednisone is and will continue to be the backbone of therapy for quite some time. They tried to run a study of doing toci early, and then kind of very little, if almost no prednisone. It didn't work very well. So I think everyone pretty much has to get prednisone. Unfortunately, it is our best worst drug. I say as a cause of and solution to all of rheumatology's problems. Prednisone is the mainstay. You got to do it. I think most patients should be on a somewhat short-ish steroid taper. I think the taper in Jiacta was a little too fast on the back end. So I give most people about 34-week steroid taper to off. Just that's my own personal practice. And then I offer pretty much everyone tocilizumab. Unless you have a contraindication to tocilizumab, I think you should be offered it. The only contraindication that really routinely scares me away is real deal diverticulitis. And I want to emphasize diverticulitis. Diverticulosis is common. Probably half people over 70 have diverticulosis. And so that is not a contraindication to tocilizumab. Tons of people who have diverticulosis get it. But if you've had diverticulitis, if you've been hospitalized because you have infection of these little outpouchings in your colon. If you've been hospitalized for that, I am worried about GI perforation in that population, and I'll often avoid it in that group. I don't think the data for that's great, but I do think that's a real risk for it. Pretty much everyone else, I think, can and should be considered for tocilizumab. It obviously increases your lipids, but we have run studies to evaluate whether or not that's a real problem. The ATTRACT study was pretty encouraging, didn't see any increased risk of major adverse cardiac events. And so I don't think hyperlipidemia is a contraindication. People are scared of needles and injecting themselves. Great. We have an IV infusion version of it. I think that for most people, it is, I at least recommend it. Now, not all of my patients receive it. I'd say probably 2/3 of my practice is on tocilizumab, something like that, because some patients just don't want it, and that is totally fine. If you're a patient who doesn't want to go on tocilizumab, then we make it work with just steroids, or we consider it an additional DMARD. Um, I am I think there's a couple different camps when it comes to what that additional DMARD would be. I am a non-methotrexate kind of guy. I don't think it works. There have been 3 randomized trials that evaluated this question, one by Spira, one by Hover, and one by Hoffman. The Hoffman study was a complete fail. Spira and Hover were both small. One looked good, one didn't help at all. And there have been subsequent studies that really didn't see a whole lot of benefit from methotrexate. So I think it's probably the most common second DMARD people use. But I will often bump people to leflunomide or Rhaba. And then these days, I think my next go-to is probably upadacitinib. It is FDA approved now. Now, that drug does have some serious adverse event issues that often make it less likely to be used, especially in an older population. But I think my current treatment is probably everyone gets steroids. Most people get offered Toci. If they want something and Toci isn't an option or doesn't work, I'll probably try upadacitinib and then leflunomide. But that's just rough sketches. Every case is different.
I think that's so interesting that you don't use methotrexate. I have to say that's always one of the options that we give our patients. But this is to your point. You ask 2 rheumatologists their opinion, you get 7 different answers. So that's
Definitely. And it's so interesting to just hear both of you in terms of your experience and, kind of doing all of these different things. But of course, we do have guidelines that can help us. And those are the ACR guidelines. So, I'm interested, Dr. Putnam, like what guidance do the ACR guidelines provide regarding first line GCA? And like, do you follow those? I mean, you kind of already alluded to this, but, are you using those when you're talking to patients? And, how's that going for you?
Yeah. No, I think the guidelines were quite good. Unfortunately, and this is the problem with guidelines, is they often lag clinical experience, right? So they were published in 2021, and it's been 4 years, and a lot's changed since then. But the guidelines recommend tocilizumab upfront. The European guidelines differ slightly. Europeans recommend tocilizumab for patients who have more of a risk factor, like diabetes, things like that. But I think the guidelines would favor an approach that says corticosteroids, less than we've been giving before, plus tocilizumab upfront. So I think that's all in agreement. um,
I'm glad that you mentioned the distinction between diverticulosis and diverticulitis, because that's something that I see often. Patients are like, oh, I was told I can't be on this drug because I have diverticulosis, and to exclude a whole class of medications because of that misconceptions, it's a big deal, actually. And so it's important to kind of make sure people are aware that that's not a contraindication to tocilizumab.
So it's kind of interesting as we kind of talk about that in the IL-6 agents because they're often underutilized. And I think that that's kind of the next question is the why. Why are they underutilized? Why is it that a lot of people just do steroids? Is it because that's just what we've known for years and years? Is it, something that you mentioned and in that, maybe people they get scared, obviously then they're not really reading too much about steroids and what's going to happen to them on steroids. But do you think that that's what it is just perceptions or just what we're used to? I'm interested to hear what you both think as experts as to why people are not maybe using enough, or maybe they're underutilizing Tosi.
I don't know if I have any great insight into this, just kind of what I already said, which was that patients just seem to be more fearful of it for whatever reason, and that perception that the risk of infection is higher. I think affordability is another issue as well, although usually we don't have problems with getting insurance to cover TOSI. Sometimes the copay is too high, and sometimes we have to do tricks of getting them the infusion versus sub-Q so that Medicare will cover it. But those are kind of the barriers I see. Some people don't like the idea of injecting themselves and they just want to do something oral. Um, yeah, those are kind of the big ones.
Yeah, I think that's a good rundown. I mean, I would say there's three reasons that people don't get tocilizumab. Reason number one is appropriate, and that's patient preference. Some people just don't want it, and that is fine. I mean, this isn't a situation where we know that tocilizumab is 100% for every patient going to save them from vision loss. Most patients will probably do okay without it, and so I certainly like the steroid-sparing effects. I certainly think that it improves outcomes, but if you're a patient who doesn't want tocilizumab, that is a-okay. The second reason is insurance company intransigence, and that's not appropriate. It's very frustrating. Insurance companies are quite problematic in this regard. And unfortunately, I think the biosimilars, which are great at a societal level, are really affecting these programs that patients have come to rely on. Give more profit margin. A lot of companies are actually reducing the amount of support they're offering, and so inability to pay is also becoming a common reason. That's not appropriate from an insurance perspective, but again, from the patient perspective, I'll have a patient tell me it's going to be $700 for this injection. What should I do, doctor? I'll say, you've got 6 syringes left. Let's space them every 2 weeks, and then we'll just go from there and stop it after that. Because like I personally would rather have $1,700. So I think you need to meet people where they are. The third reason that people don't get tocilizumab is clinical practice inertia. People just do the thing that they've always done, and we have now had this approved for 7 years. We've had guidelines for 4 years. I don't think a doctor not feeling good about prescribing it is a good reason. So those are the reasons in change over time. I mean, not everyone should be on tocilizumab, but if you're a person who doesn't have anyone on it, you probably need to consider it more often.
Do you typically start your patients on every other week or weekly
Yeah, that's a
tocilizumab?
great question. I mean, if you look, so there's no that was not tested in the Giacta study. When you run a randomized controlled trial, you only get so many bites at the apple, right? And so they didn't necessarily compare those regimens to each other. If you squint at the Kaplan-Meier curves, sure, it looks like weekly dosing worked better. So I my standard practice is to prescribe weekly tocilizumab if we're doing injections. And then my standard practice is to space that to every other week at 1 year. I think that is often better if there is any cost issues. For many patients, they don't need to be injecting themselves quite so often, and maybe a better risk benefit balance as well, although that's entirely speculative. But yeah, I'm routinely starting with weekly upfront. And then for folks who are Medicare specifically, and if they've had issues with pain for drugs in the past, I actually go straight to infusions because it's more likely that they'll get covered under that particular program. How about you? Are you a weekly kind of person? Are you every other? Or what's your lead?
I love this. So we do the opposite. We start patients on every other week, with the rationale being that if it seems like it's not holding them, we have that option of bumping them up to weekly to just provide more coverage. And so, each to his own. I don't think there's a right answer there. That's why I was curious what you usually do. And if you kind of promote the drug or sell it, I guess maybe it's a little more palatable to the patient if you say it's only every other week versus once a week. But that's up for debate as well.
Yeah, no, I actually did not see that coming, but that's not it's totally reasonable. Again, this isn't like I mean, this is an important part of therapy, but it's not the end all be all. And every other week is probably as good, probably.
Well, so here's a question for both of you that I'm just curious, and I've heard this kind of debated on a stage is and maybe for my own practice, so I assume it's going to help our listeners. Do you stop it? Like when do you stop it? And is it one of those things that is the patient just on Tosi for the foreseeable future? I'm going to ask another question that's going to go along with this, because I know everyone's going to say the same thing. Well, then I try to go to every 3 weeks, and but then how do you judge when you put them back? Oh, I'm interested, Dr. Putman. You said you did, so yeah. So tell me, what do you do?
I have 0 people on every 3-week tocilizumab. I mean, just stop it. Don't futz around. I don't know what the value of every 3-week tocilizumab is. It may be something, but if you're at the point where you're stopping it, just stop it. So I don't do that. I think you saw my Facebook. Um,
Yes, that's super interesting.
I'll feel this one first, then find out that I'm doing everything wrong shortly thereafter. So I would say that it is very patient dependent. I'd say my standard approach is weekly for a year, every other week for the next year, and then offer the patient the opportunity to stop it. I don't think this is a forever medicine. I have a lot of patients with GCA who went into remission, did great, and I'm following them, many years later, and they're doing absolutely great. And they're no remission, no relapses, nothing. And I'm glad that they weren't on tocilizumab for all that time. So at 2 years, I usually offer people the opportunity to come off. Now, there are some mitigating factors. Some people have a really bad experience with it, and we often will wind up stopping it at 1 year. Some people have no bad experiences whatsoever. They have no insurance issues whatsoever. And maybe they have a little less rubber to burn. And I know it's kind of a weird way to think about it, but if you're a patient who's lost vision completely in one eye, I saw a gentleman yesterday who was in that case. Um, you only have one eye left and you really got to protect that eye. And so there are folks in that situation where I just don't think they have quite as much rubber to burn. I mean, if they have one ischemic event, that could be the last day that they can see things. And so people who have had substantive vision loss, or people who have large vessel involvement, I will often continue much longer courses of tocilizumab. I always try and get people off steroids, so that last 5 milligrams I'm a little less aggressive. But there are people who are on tocilizumab in my practice for many years. Naomi, how about you? Is that similar? Or are you like totally the opposite?
Nothing you said is right. No, I actually everything you said is exactly how I practice as well. So um, I'm with you. We either have them on every other week, once a week, or we just stop the drug. We don't really do this kind of spacing out thing. And then similarly, it really depends on how much damage they've already sustained. So I was thinking about a patient we saw last year who presented with bilateral blindness, and there was no regaining the vision. And that's what everybody always worries about. And so we actually didn't start her on any steroid sparing agent because you could argue why. You've already lost your vision. You don't really have much else to lose. Now, ironically, as she tapered her prednisone, she actually developed inflammatory arthritis. And so we ended up starting her on Tosi anyways for that. But that argument still stands. And so I completely agree with you that if you've already lost vision in one eye, that burden of disease or damage is quite high. And I think most patients would probably be terrified to stop the drug because they don't want to do anything to increase their risk of flare. That being said, I think it's important that you keep monitoring them because most patients do well, but some flare, and you'll see them years later, and they'll be presenting with new symptoms of flare. So you don't want to just kind of send those patients out into the world. You want to continue to follow them and track their symptoms and kind of guide them on what are those red flags that you need to call us about, and um, that sort of instigates further workup on that.
Yeah, I always tell my patients we'll be friends for a very long time because this is not a 2 years and you're out of my practice kind of disease. I will be following you for a very long time. And then to your point, I review very specifically. Have you had this? I run the questions with them every time. Any vision changes, any jaw tightness with chewing, any headaches, any scalp tenderness. Have you had any new large vessel symptoms? I go through the symptoms. And eventually people become very acclimated to those symptoms and they understand and they know when to call you. And I think just hammering that every time so that people know when to reach out is really important because you're not going to be seeing them every 2 months forever. Eventually, it's going to be some big gaps in between. You want them to be educated and to know what to look for.
Right. And that's kind of when you can make that decision of, okay, maybe you were off therapy. We need to get you back on steroids, get you back on, Tosi. etc. And so now I want to shift things a little bit just to I was doing a podcast with someone and they called steroids the devil's candy. And I've used this now in the clinic, like when I'm talking to patients, because I'm like, it's the devil's candy. But it is, right? Because, obviously steroids are completely life-saving game changers for us. But I guess my question to both of you is, how are we talking to our patients and what should we as clinicians really be cognizant of when we're thinking about patients that are on steroids in terms of the complications? What should we be doing to monitor, et cetera, for our patients with GCA? Because often they are at higher doses of steroids than, for example, just PMR or from some of the other things that we're treating. So what are we telling our other clinicians and patients? Dr. Putnam, what do you do?
Oh man, I scare the bejesus out of people.
Yeah,
I
for
I
good reason.
Yeah, I really struggle with this. I mean, steroids are necessary, so you got to use them. But I think patients get way too much often, and steroids cause enormous harm to people. So I'd say that as far as people go, I'm on the lower side of steroid exposure. I think I taper quicker and I'm more resistant to going up than most people. And that's just because I think that there's no solutions in rheumatology. There's only trade-offs, and you can increase the chances of preventing events, or you can marginally affect symptoms and things like that. But every steroid that you give is another opportunity for someone to lose bone mass, develop fractures, cataracts, glaucoma, weight gain, diabetes, high blood pressure. I actually call it the riot act in clinic because I got to read you the riot act, and I apologize, but you need to know all this going into it. So every one of my patients has heard at least a dozen horrible side effects from steroids. I think that's necessary. And your patients, this observational study I published about 10 years back, 86% of people with GCA develop glucocorticoid related side effects. And that was before we had the GTI to really look into all the nuance of it. And so, your patients need to know that they're going to develop these side effects, because when they do, it's so much better that they can say, this is rough. I appreciate you warning me, than coming back and saying, well, where'd these cataracts come from? I didn't know that was a thing. So I think making sure people know and trying to avoid them whenever possible is important.
Naomi, what about you?
Well, I think even low dose prednisone, we know now there is that paper that came out, I think in 2020, looking at the risk of infection. And so even 5 milligrams or less can put patients at a substantially higher risk for infection. And then most of our patients are, GCA, they're elderly, and they're probably on a second immunosuppressive drug. And so we do have to be mindful of that. I think it's also important to just know what a true sign of a flare is versus something else. So not every headache is GCA, and people are sometimes reactive. So they will just presumptively increase their prednisone. Anytime the SED rate goes up, even if they're feeling fine, they'll increase their prednisone. And so just educating them, patients and their primary care docs and neurologists and everybody on the team, kind of what necessitates a flare, what necessitates increase in prednisone, because often I think people just get scared and so they just bump up their steroids, and then that ends up prolonging the patient's exposure overall. And then don't forget about routine kind of things that we have to take care of: osteoporosis, like Dr. Putnam said, keeping an eye out for diabetes, infection, bruising, all of that fun stuff that comes along with prednisone
I
use.
think that's very well put. Just very well put. I think the thing I see most common from folks getting as a second opinion is people receiving steroids that for just a erroneous cause. It's like, yes, you have a headache, but you had an aura and you had a history of migraines. You don't need steroids for this. And they may make it better, but you should not be on 20 milligrams of steroids 19 months into this, So just making sure that you're not chasing things like that. ESRs and CRPs in isolation are not a reason to go up on steroid. There are reasons to be careful. You should follow people closely, but I do not increase steroids for just inflammatory markers either. So I think everything you said there is really the key point: is knowing when to actually go back on them is really challenging.
I tell people that the acute inflammatory markers are a piece of the puzzle, but we don't treat, as you said, in isolation just based on that alone. It's very important for them to know.
So how fast do you taper steroids? I'm very interested because I have a feeling maybe you guys will be the exact same, which would be interesting. But Dr. Putnam, how fast? You mentioned you go faster. So what does this look like? A new patient comes in, with confirmed GCA. Let's say they don't have any vision loss, which is obviously what we're always hoping to prevent, and they say, "Okay, doc, what do I do now? What do you do?"
That's a great question. I would say, okay, so I would say that I am faster than most people, but most people are way beyond what was studied in the JACTA study. So just going by the JACTA study, you can actually look up the protocol. It's like in the supplement. You can see the exact regimen. I have a dot phrase for that. I just put JACTA taper, and it like spits out this whole long list of all of the various doses that you will be on. And then I also have a order set that I send to the pharmacy with very precise instructions and all this stuff. And so I just have like a package of things I prescribe to everyone up front because you just don't know who is going to flare. And so I think everyone should get sort of a standard approach up front. Now, caveat there, I think the actual Jack's taper was a bit fast. I think that it was really good up front, got people down to a low dose of steroid in a reasonable time frame. But once you're at like 3 to 7 milligrams, I just don't think you're under quite as much pressure to taper quickly. So once I get down to those smaller numbers and I'm tapering by 1 milligram every interval, instead of every 2 weeks, I bumped like every 3 or 4. And so my taper is just as fast as Jacked up front, but then a bit of a softer landing. And everyone that I see, I give that up front. So Naomi, what am I doing wrong? Let me know.
No, I just started a patient on prednisone yesterday, a GCA patient using the Giacta protocol. So I was kind of refreshing my memory on it. So it's starting. Well, we started this guy on 40 milligrams and then taper by 5. I think it's weekly, right? And then I kind of just trailed off in my message to the patient because I think we just have to see how things go. Once it gets to 10, it's hit or miss, and it really depends on the patient. But I'd love if they could taper by 1 milligram every 2 weeks. Realistically, it doesn't always happen like that. And as I don't know, my boss always says we're kind of just making it up as we go along to some degree. So,
Yeah, I had a conversation with Mike Walsh a while ago, and he said, the thing everyone forgets is that steroids are titratable, and it really stuck in my head because we're talking about all these standard tapers, but steroids are titratable. And if your patient starts to feel a little worse, you can always go up. So my patients, I have a little line there that says, if you start to feel a little bit worse, go to the last dose that worked and contact me. Because often, you're going from 12 and a half to 10, and 10 feels a little worse. Just spend 2 more weeks at 12 and a half and then try again. And I find that like often with steroid tapers, what I'm really doing is dose finding. I'm trying to find the threshold where the patient is no longer adequately controlled. And this is one reason that I like the 26-week diaxial taper as a starting point, because you find that dose quickly. I mean, most people still use something like the standard dose from Giacta, which I just think is too much steroid for most people. And you may avoid having a couple people feel worse briefly, but I think that you're giving a lot of people more steroid exposure than they need. And so that's why I try and find the spots. And then if you find that spot, then just like Naomi said, you kind of futz around and just accept that it's not going to, I'd say the number of people who follow the taper exactly is a minority.
do you often give patients pulse dose steroids at the beginning?
I think we're overusing pulse dose steroids. I really do. And I am not convinced that we need to use them for threatened vision loss in all cases. And that is a minority opinion. I suspect many people would feel similarly, but I would say that every single patient with threatened vision loss, I give pulse dose steroids to. It's the guideline recommended therapy, and I don't know that we could get away without it in many cases. And so I think that threatened vision loss is such a serious complication that I think pretty much every single person who has threatened vision loss, I'm recommending pulse dose steroids. I often feel like it was not the right choice, but I am recommending it. How about you? Same thing?
No, same. Just because if anything did happen, that would just be awful to
Yeah, I would
miss.
say in one time I gave some 500 milligrams of steroids instead of a gram because I was like, this is just so silly, a whole gram of steroid. And their vision, they lost a little more vision afterwards. And I just can't imagine that was the reason, but it haunted me. And it's not just everyone gets a gram, gram for 3 days and call it a day. And There is actually talk about running a randomized trial to investigate this. I am hoping that it happens, because I imagine many people will get away with a lot less than the pulse. Pulse dose steroids, I mean, you mentioned that there's evidence that even 5 milligrams is damaging. Yeah, a little bit, but like a pulse dose steroid really affects your body. And that is not a benign therapy. And it's a big thing. And so I only do that for threatened vision loss, but I always do it for threatened vision loss, and I never feel great about it. That's that's how I'd frame that home.
To be honest, I can't remember the last time I've given pulse dose steroids for threatened vision loss. I don't think I have patients reporting that very often, which is, I don't know why actually, but it's just interesting now that you mention it. I
Well, I
don't
would
think we
say
do
that
that.
vision loss on therapy is very
Rare.
rare. Very.
That's rare. Yeah.
So, I mean,
Yeah.
the people I'm saying threatened vision loss, these are all folks who I'm just meeting for the first time. And often you don't even know if they have GCA yet. So I mean, I'd say that patients who are in my practice, who have have GCA, they're on TOSI, they're on a little bit of steroid. I mean, I those people very rarely have threatened vision loss in my experience. And especially very rarely have any vision loss at all. I feel like if you can get past that first month, most people do quite well.
Well, and that kind of leads me to another question, which is, how are you monitoring for these disease flare ups? Is it, kind of what you mentioned earlier, Dr. Putnam, with just, hey, no, these are the symptoms, like these are when you need to call us, et cetera? Is it, you're monitoring, you kind of already said this, but like, are you monitoring inflammatory markers? Is it, what is it that you do to monitor for disease flares?
It's all about the symptoms. The problem, the great thing about Tosi is it's very tocilizumab. It's very effective at suppressing these acute inflammatory uh, markers, but it completely suppresses your inflammatory markers, whether or not your disease is well controlled. And so it's almost pointless. I mean, checking ESR and CRP in someone who's on tocilizumab is essentially just testing to see if they're taking it. I mean, I can count on one hand the number of patients who have had persistently elevated inflammatories on tocilizumab. They're all very ill. I mean, they have Vexus or they have some horrible malignancy. It's not just the giant cell arteritis. So I mean, this includes people with horrible large vessel disease, really aggressive inflammation. So it's all about the symptoms, patient education, know their symptoms, and then seeing people back. Continuity. Naomi, are you doing any fancy tech things over there, or anything new or exciting, or just the same old tried and true, asking people how they feel?
We are doing a lot more MRs of the cranial wall vessels, the cranial vessels. And so that's kind of a new trick that we are doing. And also a lot more pets. But then we have to deal with how to interpret those and what do we do with those findings, which is not always easy to figure out, especially if patients are asymptomatic. What do we do?
Yeah, I would echo that. I'm using a lot more imaging, and I kind of love it, but there's pitfalls. I had a referral a little while ago for a patient with an MRI of their head and active temporal arteritis, and I was like, "What is that?" I went to radiology, like, "Yeah, that's a vein." I'm like, "Okay, great. That's that one doesn't count." So, this is operator dependent. You need to make sure that your local people know what they're doing. So that's the first caveat with imaging. And the second is, as you kind of alluded to, you find all kinds of stuff, and knowing what to do with that is a really open question. The NIH group published, they had a paper or an abstract at ACR, I think it was published in February, that was discussing just like, if we actually do serial PET scans on our patients with GCA, even the ones who've been in remission for 6 months on therapy, we see tons of inflammation. We're talking these PET VAS scores of like 20, 25, like a lot of inflammation. It's an open question whether we should be treating these and how aggressive we should be about the subclinical findings. And so I think that often I'm using imaging modalities to confirm what I already believe. I'm like, I think this person is active, but there's some clarity about this, so we get a PET. I'm like, okay, yeah, this is the GCA driving this. Where it's like, I think this patient isn't active, and if a PET was normal, I'd feel real good about it. Hard when they're discordant though. And I always recommend erring on the side of just your clinical experience, or the clinical symptoms, as opposed to the imaging. But I really like PET in this disease. I'm more a lot of them.
We are getting more and more of them. It's funny, the one modality we didn't mention is physical exam. Remember that?
Way to bring it home. I love it.
It's true. I mean, and I could also say just from like a community-based perspective, PET scans are not exactly like often easy to just obtain, or get it covered, so we kind of run into that in our hospital system. But um, I have, so that's all super interesting. It's talking to the patient, it's the symptoms, and then, using, the physical exam followed by potential imaging if you're questioning it is kind of what I feel like I'm hearing you both say what we should be doing in our practice. I have one more question, which is, somewhat of a loaded question, but where do you both think current therapies fall short in meeting the needs of patients with giant cell arteritis? Naomi, I'll start with you.
We need affordable therapies. And I think we need therapies that it would pie in the sky would be allow patients to avoid steroids completely. Why not? If we're asking for this, I think that would be great. Um, Maybe a medication that we know would put them in remission forever. There's always that question, right? And we've already talked about this. When you stop the drug, are you going to flare or not? And I think that even if patients seem like they're doing well, I know that's always hanging over them. Is this headache a flare or is it just a headache? Is this twinge in my eye? Am I losing my vision or do I just, have a twitch in my eye? And that's that. It would be great to have a therapy that would put those fears to rest.
I think it's well put. I mean, better therapies, better efficacy, and fewer side effects. Obviously, I think that would be the main thing. And unfortunately, we just heard the IL-17 trial it was unsuccessful. I had actually been hoping that would be like sort of our third or fourth mechanism in the DMARD category, and I was kind of excited about that. So that's unfortunate news for sure. The one thing that I would add is that I think we need more investigation of steroids. That I don't think that it seems like we'll be able to get rid of them soon, but there are probably some people who could get less steroids than the GIACTO trial. There are probably some people who need more, obviously, upfront, and it'd be nice to have more prognostic information. That's always hard to gather. But the number one thing is we should be randomizing people to different regimens and different approaches. So we should randomize people to a pulse up front and then a super fast taper, or pulse, no pulse for vision loss. I think there's a lot of basic scientific questions we could be asking, but that we wind up not asking because there's no one who's interested in funding that. That's ultimately the problem, is that we're getting really good at running big, expensive trials. And so my number one ask is to change that system to one where we're basing our trials off of meaningful clinical questions. I mean, should patients be getting aspirin when they have threatened vision loss? We really know very little about that, which is astonishing. Do people need a pulse or not? We know very little. The only trials of different steroid regimens excluded people with vision loss, the exact population where we need it. So I think that more studies in that area would be potentially very, very practice changing and useful. And unlike our perfect medicine that we're hoping for, I think they're are imminently feasible. We just need the funding and structures to do it.
I think I agree completely. I'll add just one other thing if we're talking about dreams is better biomarkers to predict disease behavior, disease flare, um, characteristics. Why not? That would be wonderful.
Are you checking IL-6 levels?
No, we don't. Do you?
No, just wondering.
Yeah.
So interesting. Well, thank you both so much. I think that our listeners will really value what both of you have said today. With that wraps up our episode today of the GCA Fireside Chat series. Again, a sincere thank you to Naomi and also Dr. Putnam for sharing their expertise and thoughtful perspectives on managing giant cell arteritis, from first-line therapies to tapering strategies and everything in between. If you found this discussion valuable, be sure to join us for the next episode, Inside the Evidence, a deep dive into the SELECT GCA study, where we'll break down one of the most important recent clinical trials shaping the future of GCA treatment. And remember, all of RhAPP's digital education, including this series, is housed on the content room on rhap.org. And be sure to check it out for more resources designed to support your clinical practice. And real quick, you mentioned, Dr. Putnam, that you have a podcast. What's your podcast again, just for our listeners so that they can download it?
This is the Evidence-Based Rheumatology Podcast. Mm-hmm.
All right. Well, check that out also. Thanks for tuning into RhAPPcast. Again, I'm Amanda Mixon. Until next time, stay informed and stay connected.